I want to turn back to the insurance question because this is something that turns my eyes into helicopters. There are pharmacy benefit packages, and then there's medical benefit packages. And we have all of these interventions. We've got transfusions, we've got ESAs. Where do they fall, or do they fall between the cracks? And does that mean it's difficult to get coverage?
Yeah, so, I want to be careful with this question because pharmacy benefits alone don't work, right? So a prescription isn't always the kind of be all end all answer. So historically, pharmacy benefits typically focused on prescriptions, pricing, and really not about the total healthcare issue or solution. That's changing now, and payers are recognizing now that we should make decisions not in vacuums and silos, but really with an eye toward big picture, that is treating the whole person, their clinical outcomes, and really viewing their healthcare kind of holistically. So we want our members to get the right care at the right time, not just the right pill. So if you combine medical and pharmacy benefits, that usually gives a better informed view about how to really manage the patient and their total overall healthcare spend and healthcare resource utilization. There's a recent white paper from HealthCore. HealthCore is one of Anthem's clinical research arms, and it showed that health plans that had integrated pharmacy and medical benefits had actually a lower patient cost on the order of $30 per patient per month compared to plans that actually had a carved out medical versus pharmacy benefit. And so if you do the rough math on something like that, if your plan, in a state had 1 million lives, that's potentially $300 million a year in total healthcare cost savings. So there is definitely a push now to integrate pharmacy and medical benefits to think about total holistic kind of cost of care.
That is such a refreshing statement. I've been talking to payers for decades, and I've got to tell you, yours was the single best answer I've ever gotten to this, which is amazing. It's wonderful. You said that you'd rather treat the patient, not just give the pill. And that if you integrate these together, which always seemed rational to me, you might actually reduce healthcare costs. Was that a surprise to the community?
Maybe for some folks, but from a clinical standpoint, like you just said, it really makes sense that if you combine, every treatment option you have in your armamentarium, clearly you'll drive to a better healthcare resource utilization. So not surprising, but it definitely gives us the population health data now to really think about total cost of care and integrated plans versus siloed, just the pharmacy benefit compared to a medical benefit.
Do we have a handle on the burden of the complications of the ESAs in terms of healthcare costs?
So Dan and Bob both alluded to this. ESAs now, given all the data that's out, people are well aware of their complications. They're very well understood by the clinical community, thanks to FDA black box warnings and some of the studies that Janet just mentioned, Acquire and Treat specifically. So the economic burden of ESAs actually is not as significant as you would think. More importantly, I like to just stress that clinicians utilize these drugs appropriately. I think they have a place in the toolbox and should be used appropriately. There is maybe some associated increased ER utilization in people who are on really high doses of ESAs for things like hypertensive emergency or urgency. But as Bob alluded to, if you have a patient who's resistant to an ESA, you want to start thinking about pulling those back or holding those anyway, because you're not really getting